Good morning. My name is Klaus Madsen. I'm a consultant with Cities Changing Diabetes Houston. On behalf of Cities Changing Diabetes Houston, I'd like to welcome all of you to our World Diabetes Day celebration. Today, we're celebrating everyone who are impacted by diabetes, people living with diabetes, their family members, their neighbors, and their team of medical and public health professionals who are supporting them. Diabetes impacts all of us, and we are so happy that you're joining us today. There are over 37 million Americans living with diabetes and another 96 million Americans living with prediabetes. Today, this event is really important to us. As part of the Global Cities Changing Diabetes network of more than 45 cities, Houston is doing its part to innovate and to implement new solutions to address health inequities in diabetes and prevention. Houston is an international city with nearly 1 in 4 being born abroad. Immigrant communities and communities of color in general are adversely impacted by health disparities. Our hope for the time together today is that you walk away with a better understanding of what can be done when we work together. I welcome all of you to our World Diabetes Day celebration, and let me walk you through the program here. We'll start off with a keynote by Hope Galvan, Acting Chief Health Officer with Harris Health System, and then we'll have a very engaging panel discussion moderated by Tanweer Kaleemullah from Episcopal Health Foundation. During the panel discussion, Hope will be joined by Joy Cornthwaite with UT Health and Reverend Okoli and Marcela Casares, a community health worker. And then at the end of the program, you'll receive an update on Cities Changing Diabetes Houston by Stuart Nelson, Acting President at the Institute for Spirituality and Health, the backbone organization for cities here in Houston. And then Reva Verma with Renica Digital will give us a short demo of our website, My Diabetes HQ. I wish all of you happy World Diabetes Day.
Hey, good morning. Can y'all hear me okay? All right, thank you. So thank you, Klaus. Great to be here today. My name is Hope Galvan. I am the Interim Chief Health Officer here at Harris Health System, and happy to be here today. I'm going to just share my slides right quick. Sorry for the delay. I am clicking present and I am sharing my screen. Just bear with me. All right, here we go. Okay. Let me just do this. I apologize for the delay. Okay, very good. Thank you. All right. So again, Hope Galvan, what we're talking about today is health equity and diabetes prevention and care. So as we start, we kind of just want to look at diabetes today. We know that 96 million adults have prediabetes and 1 in 3 adults have prediabetes, but 9 out of 10 don't know it. When we look at prediabetes and we look at diabetes, when we're looking at prediabetes, we're looking at a much less cost in the prevention piece of diabetes. So as you can see here, the average cost per person is about $500, right? But when you start looking at diabetes, in this case, diabetes type 2, we do see that for every dollar of every four in U.S. healthcare costs is spent on treating diabetes. That said, I really want to point out the billions of dollars that we spend in reduced productivity. So for instance, you see here in front of your screen, it says $90 billion on reduced productivity. What we really know about diabetes today is that, needless to say, as you see here in front of you, investing in pre-diabetes is going to be much less expensive, right? But once we are working with type 2 diabetes and the person living with that, the cost factor starts going up. And where do we see those cost factors? Most of the money, about 30% of the cost in uncontrolled diabetes, is on the inpatient side. And what you see on the inpatient side is that the Hispanic patient population is more at risk for hospital admissions, next to the African American patient population. The cost is all, I mean, it can be anywhere from the hospital stay itself, from amputations, from lost productivity. There's so much that goes into the hospitalization cost for the patient. So when we talk about hospitalizations and we looked at where our patients are coming from, here at Harris Health, what we discovered very early on, and also across the country, I'm sure you've heard, that diabetes prevalence, a lot of times you have to look more at the zip code than the genetic code, right? So here, back in 2019, actually UT did a publication, and it was written up on the Houston Chronicle, where they talked about that the zip code for the patient living with the zip code was more prevalent, was more telling, I should say, was more telling of the health status of an individual than their genetic code. What we mean by that is that it matters where you live. And why is this important? It's because, you know, for us as a healthcare system, we are well aware that our patients, especially with patients with diabetes, they're with us 3, maybe 4 times out of the year. But this person really where they live is in that community. So if that community is very telling of their health, we all should be very well aware of that and know how do we manage this? How do we deal with this? That said, with the community, we have to look at some of the drivers of health disparities. And when we look at health disparities, what do we consider? And for those of you that don't know what health disparities are, they're driven by social and economic inequities. And here, what you see in front of you is what are some of those health disparities or some of those drivers of health. It's economic stability. It's the neighborhood and physical environment where we live in. It's the education that we attain, the food that we're exposed to, the community, the safety and the social context, the healthcare systems as well. When we take time and we address some of these health disparities, so for instance, in the economic stability, employment, income, you know, the support that we give for debt. In the neighborhood, we look at housing, at playgrounds, at the zip codes, what I mentioned earlier, education. When we look at the literacy level in those communities, in all of these different domains, us as healthcare organizations, the community as community leaders, we're well aware that health and well-being is measured through mortality, morbidity, life expectancy. We also take into consideration healthcare expenditures. What we're aware of is that we have to take time to really look and see what is that driver of health in that community. And so that's important because, and I'm sorry, my computer's kind of acting up a little bit. I apologize. How do we focus and how do we put attention to some of these health disparities and some of these social economic factors? So what do we want to do? We want to look at some contributors to therapeutic inertia. When we talk about therapeutic inertia, we talk about not only the social drivers that we're working with that are leading to health and well-being or lack thereof, but also to those the first and foremost contributors to therapeutic inertia. When we look at the clinician and we look at the patient and we look at the health system, we really have to think about, what are we doing in our practice? What is our patient seeing or experiencing from us? What is the community experiencing from us that leads to this particular inertia? So we look at the time constraints of a clinician. We looked at competing priorities, treatment, lack of medical nutritional therapy, and diabetes self-management education support utilization. I mentioned earlier that these health disparities we have to take into account. But before right when we're looking at the health disparities, and as we're looking at therapeutic inertia, we have to look at all of these different things, these different contributors. That said, when we look at our patient population and what contributes to therapeutic inertia there, we look at medication costs, the social drivers, going back to the health disparities that are driven by social and economic inequities. We look at disease progression. A lot of our patients aren't aware of what diabetes is, much less what are the long-term complications of diabetes. That lack of knowledge is critical when it comes to the therapeutic inertia. Lack of medical nutritional therapy or diabetes self-management education support and participation from the patient's perspective. A lot of times that is driven by poor communication and poor knowledge that we share as clinicians with our patients as to why this is important. Another contributor from the health system perspective to therapeutic inertia is medication calls from the healthcare system, lack of transparency in how we manage our patient population, the lack of diabetes self-management education support and medical nutritional therapy. Also, the lack of being patient-centric. What do I mean by being patient-centric? Are we using the same language that our patient uses? Are we asking permission from our patients when we are trying to provide them with diabetes self-management education and medical nutritional therapy? What we delve into is that we can do better. When we are looking at our patient living with diabetes or our person living with diabetes, we have to consider, how do we start? We can start by screening. We know that 1/3 of people with diabetes do not know they have diabetes. We can do better by our treatment, knowing that only half have good glycemic control. What leads to good glycemic control is knowledge. It is being able to make sure that our patients have what they need from the healthcare system, from the community. From the community, we look at social support. From the healthcare system is access to care, medications, treatment. Only half have good glycemic control. We have to look at food, their education level, their neighborhood, their economic stability. When we consider treatment, we have to consider all of those social determinants of health as we're delving into what is best for our patients. And the last but not least is that I mentioned education. Less than half receive diabetes self-management education. Patients living with diabetes have been well studied. And what has been well studied is that diabetes self-management education support is very impactful. And that is really important when it comes to being able to self-manage. I share here with you a social ecological model for diabetes and health equity. And why did I decide to use this resource from the CDC Health Equity Resource Kit? We've looked and we've talked about diabetes self-management education being key. We've talked about how the community plays a key role in the social determinants of health and how we as healthcare systems need to be well aware of this knowledge. And so what I share here with you is the model that shows the smallest impact starts at an individual level, but the largest impact is based on policy, health systems, and structures. And what you see here in front of you is that at individual level, it's a small but impactful value, but it's again, on the lower side because it's only one person at a time. The knowledge, the attitudes, and behaviors of this individual should be addressed, right? But again, you're dealing with just one person at a time. But when you start adding the interpersonal, which is family, peers, social networks, and associations, that domain starts getting larger. The impact is larger. And so why do we want to consider this? Is, I'm very glad to have Marcella in this particular presentation, because this is where we start now making this domain part of the community, and where we start seeing an impact rise. The next piece of this domain is the institution, organizations, community, the social networks, the norms and the standards, the rules, regulations, policy, and informal structures that, add to the impact of diabetes management when we take these domains into consideration. And then the last but not least is it's bigger than us, right? We have to take into consideration local, state, federal policies and laws to regulate and support healthy actions. And so I share this with you because the CDC has done a wonderful job in their health equity resource kit that demonstrates that as we start looking into diabetes, obesity, prevention, and any one of our initiatives as it relates to the better management of patients, is that we've got to move from a small impact at an individual level to a larger impact that includes all that you see in front of you: interpersonal, institution, community. Without the village, we really can't accomplish much in the care of diabetes. So I want to move on to just give you some exemplar equity impact. Let me just move this slides there. There we go. Okay. What you see here in front of you is just kind of an example of how Harris Health has kind of engaged in the betterment of diabetes management, but taking into account health equity as well as partnerships. At Harris Health, we had a problem. We identified diabetes disparities among different race and ethnic patients across our clinics. And what we saw was that A1C control was very much a problem, much like a lot of our organizations. And when we spoke to our patients and we spoke to our clinicians, we found that the root cause was a knowledge deficit. And so what we did was that we included healthy food when we were trying to create this initiative. And it's called our food pharmacy at Harris Health. But we also decided to add nutrition knowledge and skills to better manage chronic disease for these folks living with diabetes. So it wasn't just about addressing diabetes self-management education. And it wasn't about becoming food distributors, because we knew that our patient population at Harris Health, being of the lower economic side, did struggle with access to healthy food. We decided to combine everything and work with our partners. So we worked with the Houston Food Bank to help us be able to provide 30 pounds of healthy food and nutrition counseling to our patients who are food insecure. And what we did was create a program that also provided education. And then at the end, what we added was, and mind you, this was probably maybe a year into the program, that we discovered that by addressing food insecurity, addressing diabetes control, working with the Houston Food Bank, and working with some of our other local partners like HEB, we found that the patient wanted more support from the community. Now, we have a community health worker home visit program, but our patient population, being that, again, they live out in the community, were expressing that they also wanted that home visit, just to have somebody come into their home and see what is in their pantries. How can you help me cook? Am I picking the right choices? Am I getting the right meal portions? So what we did was also add the community health worker home visit program, but that we already had established. We had a community health worker home visit that was started back in 2017, but it was a little bit separate from our food pharmacy work. But I use this example that we now started adding this piece because we've grown. We've grown in how Harris Health Food Pharmacy Program has now engaged our community health workers, because what we mentioned earlier, in order for us to be able to address those health disparities, in order for us to really get to know our patients' social determinants of health or social drivers of health, was getting into the patient's home. And so again, this example is really a combination of the whole village coming together with partnerships, health systems, grocers, HEB, a community-based organization such as the Houston Food Bank, and last but not least, going to where the patient is in their home. And so I end with the opportunity. What is the opportunity for us today as we look at the theme for World Diabetes Day, which is education to protect tomorrow? People living with diabetes type 2, we have an opportunity to make Harris County a healthier, more equitable place to live. Cities Changing Diabetes is on the forefront of addressing the systemic issues to reduce health inequities by partnering with different organizations. Harris Health is positioned to pioneer and accelerate novel approaches to improving health equity for vulnerable populations. Harris Health System has 56% of uninsured patients that we take care of, but we can't do it with that kind of uninsured patient population. We can't do it by ourselves. We need the communities. And I think everybody on this call today needs the communities, because the community is the engine for educational achievement, for economic growth, for safety, and reducing crime within our community, to be able to lead community health. So I end this presentation today with just saying it truly takes a village, but in Houston, there's a lot of opportunity for us to make it a healthier place by really taking this year and next, well, this is already the end of this year, but really taking 2023 and using these theme for today, which is education to protect tomorrow. We can't do it by ourselves, but if we come together, we really are set to help our patients living with diabetes grow and learn in diabetes self-management, education, and support.
Are we live?
Hi, Tanweer. We're ready to go.
All right. I just wanted to make sure.
Thank you, Hope.
Yeah, thank you so much. I appreciate it. Thank you so much, Hope. That was a great presentation. I think it's a great setup, and the work that y'all are doing is wonderful. So I'd like to welcome everybody to this portion of the program. We'll have a panel discussion. Actually, Hope will be joining us in just a moment. I think once she gets on. We, I think, as usual, have always some technical issues. So I'm Tanweer Kaleemullah with the Episcopal Health Foundation, and just as my disclaimer, anything I say here is not reflective of any position necessarily of the Episcopal Health Foundation, but I'm happy actually to be joined by everybody here. I think, do we have everybody on board? Yes, great. So we're going to be discussing in a little more depth from everybody the wealth of knowledge that our panelists have in regards to diabetes. And without further ado, let's go ahead and have each one of you introduce yourselves. If you don't mind, just let us know your name and what organization you're with, and then we'll jump into the questions. Maricel, we'll start with you if you don't mind.
Yeah, thanks for the opportunity to be part of this panel. My name is Marisela Cáceres, and I am a foreign medical doctor. I have worked as a case manager, as a health educator, and in actuality as a community health worker. Volunteer with diabetes support groups for Hispanics for more than 10 years. And right now I am being part of the Congregational Health Leadership Program.
Great, thank you. Joy?
Hi, good morning, everyone. And thank you for having me here, Cities. It's something near and dear to my heart that I know Hope and I have been a part of for many years. So my name is Joy Ashby-Cornthwaite, and I am a registered dietitian and certified diabetes care and education specialist. I work for UT Health, McGovern Med School, and I care for mothers living with diabetes during pregnancy. And also, disclaimer, my comments are my own.
Hope, I know you just spoke. If you don't mind just reintroducing yourselves for anybody who didn't listen on before.
Sure. Hope Galvan. By background, I am a nurse, certified in diabetes education. As Joy said, I've been doing this for many years. And I'm interim chief health officer at Harris Health System.
Reverend Okoli?
Yes, my name is Reverend Chuma Okoli. I am the presiding elder of the North Houston District African Methodist Episcopal Church. I'm just trying to get my congregation, help them live, and that's what we're trying to do.
And that's a great segue into this, because I think that's what's great about everybody on this panel, and what we've already heard, is there is a lot of concern and a lot of great programs and a lot of initiatives, and I think we still have the challenge in front of us. So, but let's go and start actually at the personal level. So, Reverend Okoli. So make sure correct me anytime I mess up, because I'm trying. My name.
You okay?
So you have diabetes yourself.
Yes.
Would you mind actually kind of sharing some of your experience, your patient journey with diabetes, and what's been challenging for you?
Well, let me just say, first of all, I am so blessed that I am alive today. I'm so blessed I'm alive. I traveled to see my mom in 2015, December, in Nigeria. And in February, I received word that she passed, to transition. I had to travel back in May for her burial. It's a long story explaining, the length of time of her passing and her burial. But in the Anglican community, during Lenten season, you don't bury the dead, and so her burial was late. And so I traveled back. But before I traveled to Nigeria to go see about her burial, I was experiencing some symptoms. I was excessively thirsty. I was losing my sight. I was drinking water profusely. I didn't have any energy, in my body. I could barely take 10 steps, and I'm exhausted, and I had to stop and rest myself. So, in that condition, I traveled to Africa, and while I was there, I almost died. I barely did anything. So I left the rest of the arrangements and everything that needed to be done to my brothers and my sisters. I laid down almost the entire time, not knowing what was wrong with me. I have the best, I have insurance, I've been to my doctors, and so on and so forth. But it was just the fact that I had not been screened properly. And so when I returned back from Nigeria, I went straight to the hospital. And when I got to the hospital, they did a blood work, and then the doctor comes in, and the doctor says to me, well, I have good news and I have bad news. The good news is that you have the bad news is that the bad news is that you have diabetes. You have diabetes. You are suffering from the condition known as diabetes ketoacidosis. And I did not know that. And so, but the good news is that I'm putting you on insulin, and let me tell you, it's almost like I started to live again. 30 minutes after the insulin intake, my sight was restored. I made a phone call to home, and I said to everybody at home, I can see. Because prior to that, my vision was diminishing. I was not able to see. And I just did not understand what was happening in my body physiologically, but then after that dose of insulin, my strength came back, my vision was restored, and I was alive again.
And that's actually a great example. So, I mean, you've been involved with cities changing diabetes, and just having to go through that, and in terms of the support you would need, and once you find out and have to get to the hospital, there's a lot of people whose support system is not there. What are some opportunities for, you have the medical piece, as you already mentioned, the medical piece, and the community-based organizations like yours to be able to help with some of these, and especially faith-based. Because I think we see this is a very much of a community-driven effort that Hope had pointed out in the previous one. So how can community-based organizations, especially faith-based organizations, help? Where are some opportunities?
Well, I'm so fortunate to be among these great, professionals today, celebrating World Diabetes Day. And I believe that what we are doing today is an answered prayer for communities, based organizations just like ours. This is what we do. We preach faith, we preach hope, we preach perseverance, trusting in God. We preach all of those things, try to uplift the people's spirit. But a high percentage of members that we preach to, are struggling, trying to manage these disease problems, that they are suffering from, looking for that miracle, to take place in their body, So then that means then that access, to medical care, with faith, like we're dealing with, cities changing diabetes, Institute of Spirituality and Health, when, the rubber meets the road, miracles, happen. We teach about people having faith, that we teach people that we walk by faith and not by sight, but then faith without works dies, is dead, but then when you combine faith with works, that means then the works then means having access, to what you need in order for you to live, a prosperous life.
That's a great segue. We appreciate that. Thank you so much, Reverend. And Joy, is actually kind of taking from what Reverend Akuli had mentioned. You work at Montgomery Medical School, and you're in diabetes care and education specialist. Mm-hmm. I'm going to give you a big open-ended question, so we'll try to keep it to like maybe one or two things that you kind of see. So, as people engage with these institutions, a big issue that all of us are trying to deal with is equity. And so how is health equity manifested, when you're working with professionals and that patient relationship? What are some challenges that you're seeing, and what are ways that we can fix it? I mean, like I said, this probably could be like a 10-hour session on that particular.
It could.
Maybe one or two things that you can kind of think of right now.
Yeah, I'll try to keep it short, but I think just thinking about what Reverend said about his experience, I think that asks us a very important question. It asks us to look in a little bit deeper into why we came into this field, and why we want to participate in programs like Faith in Diabetes as professionals. I think oftentimes we see people living with diabetes in clinic, but we want to look further upstream, right? So you want to take the Reverend's experience and say, what could have saved him from having to end up in a situation where he was in an ER, experiencing these horrible symptoms and fear and distress related to diabetes. And so one of the things that Faith in Diabetes, the Faith in Diabetes Initiative helps do here in Houston is it helps to address the things that come before this diagnosis, the things that come before this adverse event where the Reverend had to end up in the hospital. Preventative programs are really important. You know, there's been research related to whether or not diabetes care and pre-diabetes education is able to lower costs later on for diabetes. And one of the things can be, you know, have education sessions at church or in your communities of faith, and inform people about the importance of healthy behaviors to reduce obesity, healthy behaviors to decrease the risk of development of diabetes, and then also management and self-care behaviors that can prevent complications if you're currently living with diabetes. And so I think a lot of what you spoke of, Reverend, could ask us to be more intentional about what we're doing to prevent negative outcomes ahead of time and to make people aware.
Great. Thank you so much, Joy. Maricela, you're a community health worker and you have a medical background as well. What changes would you make to the healthcare system to make diabetes self-management more effective? And then also, I'm just going to kind of pair that up with, you know, you are in contact with community members and they experience challenges with self-management. So what are some of their barriers that you're hearing from them? So how can, you know, we make the healthcare system better about helping self-management, and then what are some barriers that we can overcome from the community side?
Right. So the first thing that needs to improve or change is the most common health disparity that exists, and this is the lack of access to care. So as a community health worker, we are the bridge there to, you know, bring that gap, close the gap between communities and the health system. So we implement all of the necessary interventions to increase the access of the underrepresented communities to the healthcare system. So helping them to establish a medical home is fundamental. Having access to a primary care, you know, to all of the services that they provide is crucial. And having access to affordable care will include not just access to see a primary care, but access to affordable prescriptions and access to specialty care. So we work very hard doing outreach on these communities. We are trained about, you know, cultural sensitivity, and our main goal is to increase access to diabetes care and self-management, you know, by providing guidance, case management, diabetes self-management education, and health system navigation. Yeah. So go ahead.
No, I'm saying, and then, you know, with the self-management from you know, you had mentioned from its access issues, you know, when they're in their homes, are you hearing things from them like, you know, this is kind of makes it more difficult for me, and from my side, for my part, so there's the access part that they need to have access to, and to get to these people who can help them. And but what are some other things in their homes or communities that are maybe barriers to them?
Right. So there are many other barriers, like, for example, the language barrier.
Yeah.
Right. Transportation, you know, very important to help them to get to the clinics when they have the appointment, get them connected with the, you know, the scheduler to schedule the appointment. The lack of bilingual capacity in many of the providers, the clinics, this is something that needs to be, you know, needs to change and needs to improve. The other thing is the cultural competency on this part of the providers. So yeah, it's important for them to, you know, receive training so they can be aware of diversity and cultural competency. The other barrier is the lack of medical insurance, of course. I think, Hope, you mentioned that 56% of the population in Harris County does not have medical insurance. So that's something that we need to help them to get insured. You know, that's, as a community health worker, we can help them to, connect them with the health system and apply for medical insurance, if possible. If they are, eligible to apply for Medicaid, we can help them to fill out the applications and stuff like that. Going out in the community, going to their homes, helping them to, learn what is the best choices related with food, things like that. This is our main job in the community.
And I think also, Marcela, one of the things that you brought up was, connecting people and creating a bridge between clinicians, community health workers are powerful in doing this. Nurses are powerful in doing this. I think one of the best things about collaborative programs where someone is having an experience with a community health worker and a nurse and their physician and their certified diabetes care and education specialist is that those individuals, when we speak with one another, we speak a different language, right? So we speak the medical and clinical language. And our role is evermore going to be to help for people living with diabetes and pre-diabetes to increase their literacy around their condition, and then be able to have conversations that are meaningful together. And I think oftentimes we say, well, clinicians are not connected. I think clinicians are connected. I think sometimes we find ourselves so busy that we might have missed or misplaced that common thread, which is to find the mission, come back to the mission. All of our missions are to take care of people living with diabetes, offer them integrity and respect while they're taking care of themselves, and allowing them to live the best life that they can live. And I think every time we come back and think about that mission, we can have better meetings around cultural diversity and culturally sensitive patient care, and making sure that our institutions have translator services for everyone so that they can better communicate their needs in their native tongue. I think that so much of this is about bridging and building that trust and really coming back to the person as the center. So I love working with my community health workers, and I love working with my nurses and with my doctors, because oftentimes it just takes one person to say, okay, I know we're really busy today. It's a wild Monday, but let's bring it back to what do we want for this person, and how can we give this person the best life that they're able to live.
Tanweer, I just want to say two things very quickly, is that I agree with you, Joy. We've all gone into healthcare for the right reason, right? To provide the best that we can for our patient population. What I will say is, going back to Reverend Okuli earlier, is like the faith-based community for us at Harris Health and Population Health, it's partnering with the faith-based community, because they're the trusted agency. A lot of our patient population, when you diagnose them with something like type 2 diabetes, it's a death sentence because they haven't received the diabetes self-management education and some of that work, that they will just see what happened to their neighbor, what happened to their uncle who ended up on dialysis and what have you. And I've heard many stories where they will go to their faith leader and say, look, this just happened to me. So it's really working with the faith-based community to educate each other, right? This is what happens in our clinic, but you tell me what happens in your house of faith, and how do we work together so that way when our patient goes to you, we're both giving them the same information. I want to go to my trusted agency to be able to do that, and that is the houses of faith. I will say from the community health worker side, I agree that access is important, but I want to take us a step back, is that how do we prepare our community to be successful? And you really have to look at, what I mentioned earlier. They say your zip code is more telling of your genetic code. What is going on in your community that is a barrier for healthcare access, that's a barrier for education, because education, poverty, all of those things are barriers to healthcare and healthcare access. So I will say that there's different perspective, at least for me, from the population health side. It's really working with my communities to learn about those barriers, working with the faith-based community, who is the trusted agency, working with our internal community health workers to be the boots on the ground in the home, but also too for them to partner with community-based community health workers to learn about each other's work in the day-to-day. So, for me, I think what I just painted, I hope, is that it truly does take a village. But we can't do it all by ourselves. And I challenge us to take it even to the next level. What is that policy that we are advocating for to make these changes, to support us in what we're doing? Because last I heard, I wasn't being reimbursed for community health worker services, right? So just something to consider there.
I think that is actually a perfect question, because we have people from different perspectives here and different levels. So you just mentioned policy, and I think it's an important piece, and policy as a way of activating our community to be involved with the will for their own health. And from all of you, you have different perspectives, and we just had an election, obviously with a lot of, it was an exciting few days. People had were glued to their TV for regardless of which side. But what are ways, I guess, this can be local. So local as far as like my community, what am I doing to help my community members? And, that could be faith-based or some other organization. What am I doing at the city and county level? What am I doing at the state level? So, are y'all aware, or do you have suggestions or are aware of some initiatives of how, policy can affect diabetes? Because there are barriers at policy and there's some opportunities there as well. So I'm going to leave that one kind of open-ended. So whoever wants to take that one.
I think there are some, in addition to houses of faith, there are some initiatives and policies in schools that have been very impactful, because oftentimes, there are health education programs that children will learn in school, and then they'll be able to take that back to their families and to their communities to even start a discussion. I think those types of policies are, they're low-hanging fruit. We can do that. We can teach kids about what it means to choose better food options, and we can ask them to ask their parents for more optimal options, and then have access to education and resources on the adult level at, say, their primary care offices, or they can go to the food pharmacy at Harris Health and now have a point at which to jump off of, and also have a motivation of their children. And so those things are, it's a very small policy of educating children at school, but you can see how it can have ripple effects throughout the family and through the community and into the church community and into the health system that is ready to receive people who are wanting to have a nutrition prescription and guidance there.
Yeah, and I wonder if Bill should continue chiming on this particular question, but I just wanted to make sure, kind of going back to what all of you have said, we were talking about, social drivers of health. What are these other things that can help address those? You talk about transportation, but you mentioned schools, which is great. So there's other things that it could be. What are things in people's lives like? There are policy issues like recess policies in schools. So not necessarily related to the healthcare sector, particularly, which is important. But what are some other opportunities where in people's everyday lives that there are things that need to be taken care of at that local or state level? So again, that's an open-ended question, so that's probably another 10 hours. But any recommendations or?
I have to say, we've kind of delved a lot more into the community. You asked earlier, Tanweer, about the community. There's so many. Just one quick example. We work with the Be Well communities, and when you have that voice in the community and you're exposed as a healthcare entity to those voices in the community, those voices in the community are the actual people living with these diseases, right? it's enlightening, because then you really get to understand what is happening in their life, right? And what I want to say is that engage ourselves in those community meetings and those grassroots sessions to be able to learn what exactly is happening in the community, not just from the disease process, because I can tell you, how many hospitalizations, how many visits, what happens when you lose control of A1C, but I can't tell you what is keeping my patient from coming into a diabetes self-management education support group that has been shown to be effective, unless I go out into the community and find out what are those barriers. Just a quick example, really, just very shortly, at one of our sites, there was a transportation issue, and it was just mostly because the drop-off was not in an ideal place for the patient population. So what did we do? We talked to our transportation agency and said, hey, we need to be moved. And they were like, wow, we didn't even know that was happening. And so it was moved, but we wouldn't have known that if we hadn't been involved with the community, hadn't gone to those community meetings to know that this was one of the barriers in this particular access to care in this particular neighborhood. So again, just kind of want to say this, we have got to be able to have boots on the ground in the community that are actually connecting with those community partners who are already having those conversations. They're already having them. We just have to be aware of them.
Yes. Reverend Cooley and Maricela, you have some roots in the community, and we've talked about the role of the church and other communities. But what are, we're putting a lot of burden on you. What is some help? What are some things that y'all would need from maybe some of the healthcare institutions, or what types of things do you need to help you help your congregants and your community members?
Well, for me, I learned today from these experts, that I'm on the panel with, that I'm one of the 1/3 that did not know that they had diabetes. One of the 1/3. What we want to do is bring that to a 0, and that's what we want to do. And I'm learning that this disease is very manageable when we can overcome the barriers, that persons who are suffering from these diseases, have, for instance, even up to today, I'm still struggling with exercise. I'm still struggling with healthy eating. I'm still overindulging myself in the calorie-dense foods as to the nutrient-dense foods. And so if I'm experiencing those problems, imagine what our congregation, I have about 20 churches in North Houston District, and within those 20 churches, we have funerals almost on a weekly basis, on every 2-week basis. People are dying. And then when you look deep into the causes of death, they are all related, to diabetes and the complications from diabetes, and so on and so forth. So what we're trying to do is, one of the problems that we face in the community is the cost of insulin. I remember I had good insurance, but I couldn't afford to buy my diabetes because I could not meet the copay. Those are the prevalent problems that some of our community members, face. That's why I'm excited, about what this new Biden administration trying to do about reducing the cost of insulin. And then transportation, difficulties. You mentioned that. You mentioned the transportation difficulties. But what we are trying to do, is trying to find a way to stay connected with experts like you. We want to be the one-stop shop that can connect people to organizations like your organizations, so that they can have adequate access, and so on. And then find ways, to deal with the transportation difficulties that some of our members have. Not all of our churches have vans that can transport people to various clinics and places, doctors' offices, and so on and so forth. But these are some of the things that we have to walk through, so that we can help our people, know that which they believe in, we work for their good.
Yeah, and this is what Hope was just talking about, right? So listening to community members like you, Reverend, who are saying these are the things that my congregation needs to know about, and then making a connection with, certified diabetes care and education specialists who can talk about things like, recently Reva was part of the team that spoke to Texas legislation, and they were able to secure a cap on insulin insured at $25. And so there are things that we can talk to congregation members about in terms of, is this an option for you to afford your medication? Maybe there's an option for using coupons or moving into a medical home like Harris Health System in order to help you meet with Maricela and sign up for programs. These are all things that start off with increasing literacy, not in the way that we think it needs to be increased, but in the way that the community is telling us that they want to hear. Right, Hope?
Right. Absolutely. I love what you just said, which is let's ask, right? Basically, and learn. I think also to add, one of the areas where we could also strengthen is those support groups, right? That peer support, because our patient or anybody living with diabetes, they're going to gravitate to somebody that has already lived it. And sometimes it's not a good thing. Sometimes it's a really good thing. So we have to support that, right? To be able to create those peer supports that are really the key to a lot of the education and information that's not in a structured program that patients get. So, but yeah, I'm with you. Let's ask.
Yeah, I have another thing to add, and is that as a community of workers, we know all of the resources available, and there's plenty of resources. The only thing that we need is to get in contact with this population, with this community in need, and then help them. So one of the other things that we need is find out what are the other community leaders, because it's not just us.
Mm-hmm.
We get connected with them. They are people that is trusted. They, the community will look for them if they need help, if they need any type of assistance. So it's very important to create that network with the leaders in the community, not just the faith leaders, but any other type of leaders. And Hope, it was Hope. Joy, you mentioned something about coupons and stuff like that. Yeah, there are plenty of things online. It's just go and find out what is available. But yes, very important to get them connected with a medical home that they really offer, that community clinics, community, how they call it, community clinics, that they offer low cost for everything, for your copays, for your prescriptions, for everything. So it's not an excuse to not receive medical care, because services are available for them. It's just a matter of connecting them with the health system.
And I think that's a great point. And I think, and kind of going back to a couple of your comments, and actually I'm taking a comment that I think one of the audience members mentioned. There's sometimes we kind of take for granted what people may know. We do know that everybody knows that they're supposed to eat healthy and exercise. There's some of these types of things, but there are particulars, I think, like Reverend Okolie had mentioned during his own personal experience. He was experiencing some symptoms, and there's some particular or resources Maricela is mentioning. And one of the comments, actually, one of the audience members mentioned, like having videos. There's some things about like passive learning that that we kind of take for granted. Just put them in an environment, especially in a trusted place like in a church, where you have a video screen and they have just like these educational videos that come up. And I think that's a great opportunity for partnership or some ways to just help our community members without having to necessarily put in the human capital part of it. So I think I think this is a good message on that. We just had a couple of years of a pandemic, and I'm not saying we're out of it. But we're transitioning. So I don't get in trouble with anybody. But we're in an endemic stage at least. And people, as we know, have experienced a lot of just mental difficult hardships, and whoever, I'm gonna leave this open. Can one of you kind of discuss like what you're hearing, and how is that connection? Because some people kind of miss that connection between how mental health can really relate and affect diabetes, and how diabetes affect mental health. So if somebody can speak to that, if you don't mind.
I want to start just from our patient population. As I mentioned earlier, 56% of the patients coming to Harris Health are uninsured, right? And they apply for financial assistance. I think what we've seen is a couple of things. The mental health piece behind just coming, kind of dealing with this pandemic. I won't say coming out of it. I will say dealing with it, because we still are. There's still people who have lost their job. There's jobs that have found places that have found ways to do things that they don't necessarily need that person back. The mental health of losing, family members to the pandemic. All of those things. What I hear on my end has been just that, the mental health piece of that's being triggered by job loss, that's being triggered by family loss, that's being triggered by life being just totally different than what it was before. Not only were you isolated for this time frame, but now all of these other things have happened. I think the mental health piece for us is the one that I'm very kind of worried about, because even at a national level, our resources are limited, right? And the attention is still it's there, but the actual interventions for it is still limited, in my opinion, especially with, certain patient populations. So I hope that makes sense. But for me, it's really the mental health that's being driven by all of these other things from the pandemic.
Somebody else have something you wanted to add to that?
Yeah, I think that a lot of people are currently working on ways to create greater access to mental health services for the most vulnerable in the population. And one of the things I think that we're doing a little bit better at, because we are all in this endemic, COVID world. I think people had this shared stress, right? I think we all are living in it. We live through the worst parts of it. But I think we can empathize on some level and recognize and sort of like check the box, like people are suffering. But we need to do better about having the resources to help someone find their way out of that. And so I think that is another next big step for us, is to figure out, how do we bring the resources? How do we make the resources available? Is there an opportunity? I think so, for remote services. Is there an opportunity for technology in this space to put mental health specialists and care in people's hands via their phone? I think very much so. I think we need to get better at doing that in order to help people deal with just their life stress. And then on top of that, the burden of living with a chronic disease that doesn't let you quit, that doesn't let you turn it off for even a minute of every single day of the rest of your life. And so I think access and utilizing the silver lining, which is tech and tech advances for during this COVID time and in history, is going to be really important.
I'll just simply say that I was one of those affected very depressively, during this pandemic that we just came out of. We're in the post-pandemic now, because I was one of those. I lost my spouse in November of 2021, and I know what I went through mentally, and then at a point where you couldn't even go to a doctor's office. All the offices were shut down, and you could only just pray, trust God to see you through what you are going through. And I think that when we have people who are broken, sometimes and depressed and have mental issues, I think sometimes the best solution for them at that moment, is to indulge in overeating, and to indulge in stuff that takes their mind away from what they're going through, rather than go through that problem and deal with that problem. And so in the faith community, I think what is lacking the most is access. Access, and finding how to access what is needed in a timely manner, before one goes beyond, a redeemable stage, and that's what we need, in the faith, community, to help our people live, to help them live, to help them distress themselves. Even though I'm a man of God, and I know many people of God who struggle through daily difficulties of life, and they want to know how can I make it through the end of the day, not just through tomorrow, but through the end of the day. Who can help me, overcome these difficulties I'm dealing with, that's stressing me out, that making me go crazy, and I think that's what the church needs, partnership and collaboration and connection with organizations such as yours, that we can point people to and say, okay, here's an answer to what you need. Keep praying, but here's an answer to your prayer. This is what you need.
Yeah.
Amen. That's for you to lead.
And I think Hope and Maricela and I are like taking notes right now. We asked, and you are delivering the answers about where we need to focus our resources and what we need to do better as the experts to get this information into the hands of people in the community so that they can live their best life. MyDiabetesHQ.org is one of the initiatives of Cities Changing Diabetes. And we have resources there that are based on the self-care behaviors from the Association of Diabetes Educators. And so many of the things you've mentioned here, Reverend, like they resonate with me, because it's the reason that I have chosen this career, and which is more of like a mission and a career. I'm very lucky that my mission in life is also my career. But you speak to knowing and being more literate and more empowered to self-care through things like knowing where to get and to develop better ways of coping with diabetes distress, with knowing how to access your medication, because ultimately people want to live and they want to live well, right? And so even if they're trying, if they don't know how, then it's like a negative reinforcement, right? I'm trying, I'm giving my all, but it's not working.
Yes.
But there are resources, and so I would say, first stop, ask us. We're here for you. We'll always be here for you. I'm just telling Hope and Maricela, but I know these are the people they are, because this is what we've done for years and years. And reach out to the Institute of Spirituality and Health, direct your congregations to mydiabeteshq.org. There's even a contact me button, and you can say, hey, I need a community health worker who will help to educate my people. You can go to faithanddiabetes.org as well, and request services for educating your congregation members who want to take a role in educating the people that they know and love. It's really great to hear you ask for these things and know that we can help.
I'm glad you said that, because I have a planning meeting that's upcoming, on the 3rd of December.
Mm-hmm.
And I want to make the focus of that planning meeting about health, about living, about, dealing with these diabetes, difficult problems that our people face. So I will need contact information from each one of you. It would be in Conroe, Texas. A few of my leadership of the North Houston District will assemble, and some of the congregation. So I don't know how many people will be there, but it would just be wonderful to have at least one or two of you to come and make a presentation. So I need your information, contact information.
There we go. That's the connection we made. So we're about to transition to the next part of the program today. But I just wanted to say, going back to from what Hope said and what has been said throughout all of this is, it does take a community to do all this. It takes extended family. It takes community members. It takes faith-based organizations. It takes us for all of us to be there for others. I think at the end of the day, it's a human-to-human thing. We do need access to healthcare. We need people who understand what their community members are going through to be able to serve them better. We need the technology and the medicines, but at the end of the day, we need the people. And I think as long as we can try to see, take the traditional families and communities, and also what are some new ways we can actually help build those communities and make it much more stronger. So anyway, thank you all so much. This was a great discussion. I think there's so many gems in this. And thank you and condolences to Reverend Nicole. I think that we really appreciate you sharing that with us and showing such a beautiful spirit and through all of this. So anyway, let's go. I'm going to go ahead and transition over. I think we're moving on. Is that correct? Bye, everybody.
Thank you.
Greetings, everyone, and thank you so much again to our panelists, as well as Tanweer, for just an amazing discussion. I think it provides a lot of food for thought to sustain us over the next few months as we think about how best to continue advancing the mission of Cities Changing Diabetes, as well as the larger community focused on addressing diabetes and prediabetes in our communities. Cities Changing Diabetes is a commitment to drive action against type 2 diabetes and obesity in cities around the world. The global public-private partnership program addresses the systemic issues underlying the rise in obesity and type 2 diabetes and aims to reduce health inequity. Cities Changing Diabetes was envisioned by and is catalyzed by Novo Nordisk, and we continue to be grateful for Novo's support and leadership as we work together to bend the curve of urban diabetes, focusing on city-specific strategies that demonstrate the ability to achieve positive outcomes for individuals and communities. A special thanks to Karen Gillespie, who in her previous role supported CCD Houston's strategy and growth for several years, and also to Apu Patel, who has been a pleasure to work with for the past year as we take CCD Houston to new heights. Cities Changing Diabetes began in 2014, and Houston immediately became one of the first cities to join. As Cities Changing Diabetes Houston began, UT School of Public Health, under the leadership of Dr. Stephen Linder, completed research to understand vulnerability to diabetes in our city. Houston also simultaneously convened thought leaders from across sectors, including people living with diabetes, to strategize around the best innovations and local solutions. Dozens of ideas were submitted, with several being chosen for further development, and these programs grew and adapted over the past 8 years, bringing us to where we are now. I included this drawing from the very first Cities Changing Diabetes strategy meeting that I was part of. And it's interesting to see what's changed and what remains the same from that initial vision. The Cities Changing Diabetes Houston ecosystem consists of 4 central initiatives: Faith in Diabetes, Houston's Diabetes Peer Support Program, Bite of Hope, and MyDiabetesHQ.org. These programs work together with local clinical partners, including Houston Health Department, Harris Health System, Hope Clinic, and Harris County Public Health, to create an ecosystem for diabetes self-management, prevention, and care, so that all Houstonians living with diabetes have the opportunity to thrive. This work is also supported by a core team, which consists of leaders across sectors who have a passion for work in this space, as well as experience and knowledge to help the initiative thrive. In a healthcare environment marked by a measure of distrust and disengagement amongst the most vulnerable, Faith in Diabetes provides an avenue for faith communities to become leaders in the fight against diabetes and obesity. Faith in Diabetes taps into the reach and influence of faith-based organizations to provide self-management and prevention programs. And the program is based on an evidence-based curriculum created by Gateway Laredo, a federally qualified health center serving Webb, Jim Hogg, and Zapata counties in the Rio Grande Valley and along the border. And we're really proud to be able to adapt their curriculum here in Harris County. Lay leaders who are trained teach a series of classes in their faith community, weaving important religious beliefs and practices together with evidence-based curriculum to create a culturally and linguistically competent experience. Our next training is going to be a Spanish-speaking focused training beginning in February of 2023. We're proud to showcase the names of the faith communities who participated in our 2022 trainings, adding to a list of over 35 faith communities who participated since 2016. Under the leadership of Serena Valentine at Core Initiative, this is a network of support groups, Houston Diabetes Peer Support Program, by and for people living with diabetes, so they may share experiences, help each other learn, and foster a sense of community. Meetings take place in health centers, nonprofits, and community-based settings, and are a chance for participants to share tips, insights, challenges, and experiences in a safe and supportive setting. Health resources are brought into groups by a trained facilitator, and the peer support team assesses participants for their health and social determinants needs and explore how effectively they can connect those participants to medical care, insurance, and other services. There are currently 5 weekly meeting groups, along with an active Facebook group where people can plug into the network, and we're looking forward to launching more groups and expanding reach through 2023. Bite of Hope is an incredible initiative under the leadership of Chef Chris Lott and Tabby Saenz at the Hope Clinic. Bite of Hope transforms the communities it reaches by promoting nutrition and wellness. It consists of community outreach, including cooking classes, after-school programs, workshops for all ages focused on healthy food choices and farm-to-table movements. We expect 3,500 plus families to have contact with the community outreach efforts of Bite of Hope this school year. There's a small food business program that helps small food businesses through workshops grow and succeed, embracing their role in health and improving the diet quality of the communities they serve. And we're looking forward to reaching at least 16 businesses in this fiscal year. In the future, there'll be more robust efforts around the Culinary Institute, which goal is to empower aspiring restaurant owners and cooks with culinary techniques and food service management concepts focused on the power that food has in health, and also culinary medicine, which uses food as a tool to help healthcare providers explore the implications of nutrition on overall health, enhance the quality of patient counseling, and tackle obesity, diabetes, and cardiovascular disease. MyDiabetesHQ.org is a much-needed resource bridging community-based programs, clinical systems, navigation resources, and basic information regarding diabetes and obesity. It provides a one-stop shop, including a YouTube channel and a podcast, navigation services, so that people living with diabetes and their families can better thrive. I'm pleased to now welcome Reva Verma, CEO of Reneka App Builders and chair of the Central and Southeast Texas Community Leadership Board for the American Diabetes Association, who will share more about the website with you. I just really want to encourage anybody who's watching that wants to learn more about the initiatives we've mentioned today. Please go to mydiabeteshq.org, where you can find the resources you'll need. Reva, I'm going to turn it over to you.
Thank you, Stuart. And thank you everyone for being here today. Happy World Diabetes Day. I'm Reva Verma, CEO of Naked Digital, and I'm going to talk about My Diabetes HQ. So I'm going to pull up the demo that we have for you all today. There you go. So My Diabetes HQ was developed through the city's Changing Diabetes initiative, which brought together a variety of stakeholders representing patients, healthcare, government, employers, faith-based organizations, and nonprofits to identify solutions to address diabetes in Houston and collaboratively implement them. None of this could be possible without the leadership from Joy, Klaus, and Stuart. So with that, I'd like to go ahead and start the demo. Right here, what you see is the static website that provides resources and information about diabetes and community partners within the Houston area. We feature the My Diabetes HQ Live video series as well as podcast here on the homepage. We cover topics ranging from issues that people live with who have diabetes, as well as from a caregiver's perspective, all the way to what healthcare professionals incur. From there, we go into the trusted and verified resources regarding obesity and prediabetes, peer support, and cities changing diabetes. In the About Us section, we talk about cities changing diabetes and how you can get plugged into all branches of the Cities Changing Diabetes initiative. We have some messages from the mayor there as well to show support from the Houston community. In the diabetes section, we have a robust resources section. So each resource is put under topics of and categories relating to diabetes. This has made it very easy to search for topics that might not be top of mind for people living with diabetes. So we have them broken up here, and then each resource is linked out. Each resource is also vetted by professionals before being put on our site so that they are trusted. In the Our Community section, we talk about the initiative Stuart mentioned, Faith in Diabetes, and different links here to learn more about each initiative. Peer support is here too. Serena Valentine, like Stuart mentioned, is in charge of this initiative. We have links here to the Facebook group for more information and how to join. And last but not least, we have Bite of Hope to introduce resources regarding nutrition and different programs associated with that as well, and how to get involved. The special part about the My Diabetes HQ initiative is that we are launching a community portal. The community portal is meant to provide almost like a virtual peer support situation where there are different topics covered for people living with diabetes, caregivers. We have a navigator there too to help put people in touch with the appropriate resource that can help them with their concerns and issues. So if you click on the community portal, this is the chat session. You're able to sign in, create an account. It's a very simple sign up form. And then you pass the challenge capture and then register for an account. These are the profile types I mentioned: navigator, pre-diabetes, person with diabetes, caregiver, and a paraprofessional. If we were to create a navigator account, the navigator is vetted with their credentials and bios, and then they log into the system, and an admin will vet their profile to make sure that no outside people can join the portal without being vetted. On the left-hand side, we have those topics I was talking about. So, for example, access to care is put in this portal. So, for example, if someone were to log into this portal and say, I need help with getting my insurance to cover a certain medication, well, the navigator has the option of intervening, creating a note section, logging the user journey so that the next time they log in, they don't have to start from scratch, and there's a way to follow up with the person who is asking for help. We're also able to put them in touch with these different entities around town, for example, like the Houston Health Department, and we can put them in touch with them here. Now, for personal health problems or personal health issues that don't necessarily need to be public information, that's what you see here, which is the private messages, so that information can stay confidential, but we can still give that person the help that they require. So these are all the notification preferences. It's a very simple chat feature. And so this is the notes feature where the user journey is logged. We're able to keep a record, make sure that we have the data there to make sure that they're getting the help they need, but also be able to provide that notes history to a healthcare professional if they need that information. Now, if we were to sign in from a person living with diabetes, they go through the same sign-up process. They're able to log into the portal with the simple sign-up form that is then approved by the administrator on the back end before being able to log into the portal. And once they log in, they're able to participate in any of the chat forums that they wish to. So that's the demo of this portal. I do know it was difficult to see because it's small on the screen, but we're more than happy to pass it out, and then feel free to go to the website whenever you'd like to explore it. It's mydiabeteshq.org. This portal is in the final stages of testing and will be launched once we have a navigator in place. So stay tuned. We're really excited to provide this type of support to the community so that people can thrive with diabetes and not just survive. With that, I will pass it back off to Klaus to give us some closing remarks.
Thank you so much, Reva. I really appreciate all the hard work that you put into developing mydiabeteshq.org in collaboration with Serena, Stuart, Joy, and many others. A big thank you to Hope, Tanweer, Reverend Okoli, Marcella, Joy, Stuart, and you for making this World Diabetes Day event really engaging and inspiring. And for all of you out there watching via YouTube, wherever you are, I know we had participation from Houston and from other cities around the world in our global Cities Changing Diabetes network, including our sister city in Philadelphia. We appreciate you for joining us. We encourage you to make a difference in the next 12 months before we meet again and celebrate World Diabetes Day 2023. We want you to make the necessary changes in your community so that we can improve the statistics that Hope shared in the beginning of this webinar. So go out there, seek out new partnerships, come up with new solutions, identify ways that you can make changes, even just modest changes in your school, in your workplace, in your community of faith, and in your neighborhood. If all of us are making these small changes, it will add up. And I know that we'll make lives better for people living with prediabetes and diabetes. I wish you, on behalf of Cities Changing Diabetes, happy World Diabetes Day. Thank you.